So it's my pleasure to introduce Dr. Visish Srinivasan, who is a cerebrovascular fellow at the Barrow Neurological Institute. Just a little place that I'm sure people have never heard of in the neurosurgery world. Dr. Srinivasan completed his medical school at Drexel University College of Medicine before joining the Baylor College of Medicine for his neurosurgery residency. He's an incredibly prolific researcher with work ranging from endovascular delivery of human mesenchymal stem cells in a glioblastoma model to the development of a novel microangioscope. So really just a great person to follow who's somewhat on a peer level with us, and we're very excited to have him be facilitating today.
Thanks, Mike.
All right, so why don't we have the first group? So Michael Mayer share his slides and get started.
Can you see my screen?
Yep, I can see it.
Okay. Okay, so I'm going to be talking about the ISAT trial, which was published in The Lancet in 2005, and this was a trial comparing neurosurgical clipping versus endovascular coiling in 2,143 patients with ruptured intracranial aneurysms. So just for some background, I know we've been talking about aneurysms the past couple weeks, but subarachnoid hemorrhage is a devastating result of ruptured intracranial aneurysms. The damage to the brain is multifactorial. There's a combination of the listed factors here, and that gives us the high short-term mortality and long-term morbidity rates that we see with subarachnoid hemorrhage. So traditionally, the treatment of ruptured aneurysms has been clipping. That involves an open neurosurgical approach with a craniotomy and clipping across the aneurysm neck with a metal clip, as seen in the top right picture. In the late 1990s, coils were first introduced, and that gave neurosurgeons a less invasive means to treat aneurysms. And this study really aimed to compare the safety and efficacy of coiling versus clipping for ruptured aneurysms in patients that were suitable for either treatment. So the methods, this was a multi-center randomized trial that enrolled patients in the late 1990s. There were 42 major centers involved, mostly in the Europe and UK. These centers treated between 60 and 200 cases of aneurysmal subarachnoid hemorrhage each year, and participating neurosurgeons were required to have done more than 30 endovascular aneurysm treatments. So this just really speaks to the proficiency of the investigators that were involved in the study. The population, patients were eligible for the study if they had a definite subarachnoid hemorrhage confirmed by either CT or lumbar puncture within the preceding 28 days due to a ruptured intracranial aneurysm, and that had to be suitable for either open clipping or coiling. And we saw a large number of patients were excluded from the trial for other reasons. Presumably, these are patients who either for one reason or another could not undergo clipping or coiling. So the primary outcome was a functional outcome. They measured the modified Rankin scale at 2 months, 1 year, and each year thereafter. And the secondary outcomes analyzed were death during medium-term follow-up angiographic findings, rebleeding rate from the treated aneurysm, and seizures. So we see that they were matched pretty well between the endovascular coiling and the neurosurgery clipping group. There were no significant differences between the groups. 95% of the aneurysms in the trial were in the anterior circulation. 90% were smaller than 10 millimeters. 88% of the patients were in good clinical grade at the time of enrollment. Corresponds to a WFNS score of 1 or 2. And there were a relatively small number of patients older than 70. So this was really the characteristics of the cohort that was studied. So getting on to the primary outcome, we can see at both 2 months and 1 year, there was a benefit to endovascular coiling in death and dependence. So at 2 months, 26.1% of patients in the endovascular group were dead or dependent, compared to 36.9% in the neurosurgery group. And that pattern persisted at the 1 year mark. So this translates to a relative risk reduction of death and dependence at 1 year of 23% and an absolute risk reduction of 7.4% in favor of coiling. As for the case fatality rates at 1 year, they were similar between groups, 8% for coiling and 9% for clipping. So getting on to the secondary outcomes, we see that the survival benefit of endovascular coiling persisted over the entire 7 years of follow-up. And as for the aneurysm occlusion rates, complete occlusion was less associated with endovascular coiling than neurosurgical clipping. So endovascular coiling may be a less durable option since it has a lower rate of occlusion. As for the rebleeding rates, rebleeding was higher for the endovascular coiling group, which may relate back to the incomplete occlusion rates. Within the patients who rebled between the first procedure and before 30 days in the endovascular group, several patients, according to the authors, rebled while awaiting clipping after failure of coiling. So essentially they rebled while after not receiving any treatment. There was a high re-rupture mortality, which the authors partially contribute to the use of thrombolytics for treating parent vessel occlusion. There are safer alternatives that are used today, but that's what the authors contributed this high mortality rate to. A critique of the study is that patients who rebled prior to treatment were included in the safety analysis. These patients who bled before treatment, there was more in the neurosurgery group. So we see that that really favors coiling. And that influenced the relative risk that they calculated of rebleeding at 1 year. As for seizures, we saw a significant reduction of the risk of seizures in endovascular coiling group at all time points. Craniotomy is known to carry a risk for seizures, and perhaps the less invasive nature of endovascular coiling can avoid that. Further analysis, this was from a later paper by the same group that analyzed the data a little further. Seizures were strongly associated with delayed ischemic neurologic deficits due to thromboembolic events or vasospasm. So essentially ischemia and MCA aneurysm location. Some limitations of the study, as we talked about earlier, there was the subjective inclusion criteria. So it was really up to the discretion of the individual neurosurgeon whether or not the patient was suitable for both clipping and coiling and therefore suitable for enrollment into the study. There was a relatively small number of patients older than 70 in poor clinical grade and a small number of posterior circulation aneurysms that were evaluated. And also, being that this was published in 2005, there were no modern endovascular devices or techniques that may improve outcomes today. So in summary, there was a decreased risk of death or disability at 1 year with endovascular coiling, and this benefit continued over the 7 years of follow-up. There was a decreased risk of seizures after coiling. When seizures did occur, it was associated with ischemic events and MCA aneurysm location. And there's an increased risk of rebleeding after endovascular coiling. Overall, the risk of rebleeding is low, but the risk was higher with coiling, and that may relate to the incomplete occlusion. So the conclusion of this study, in the appropriately selected patient, endovascular coiling of ruptured aneurysms is more likely than open neurosurgical clipping to result in independent survival at 1 year. that's all I had.
Awesome. Thanks, Michael. So we can open it up to questions and some commentary from Dr. Srinivasan.
I'll leave it open for questions first, and then I'll jump in.
Okay.
All right. So I thought that was a great job, Michael. Thanks for presenting that. So, ISAT is kind of the big time. And so, it was kind of a revolutionary paper when it came out. It's been about 20 years since that paper came out, but it's made a huge influence on the way that we treat aneurysms. So at the time, aneurysms were largely treated with surgery, and then this was kind of the hot new thing at the time, endovascular treatment. And coils had only been around for about maybe 5 to 7 years or so before the start of the ISAT trial, and the technology was rapidly evolving over the course of the trial. Since then, essentially, endovascular treatment of aneurysms has kind of become the default or the standard, and a minority of aneurysms are clipped. Certainly in the US, it's a little bit more mixed. I think overall numbers are probably around 80% of aneurysms treated endovascularly and 20% treated with surgery. And in Europe, where the majority of the trial was done, it was kind of centered in the UK. It's even more so, it's maybe 90-10 or more. So this has had an outsized influence in terms of how people treat aneurysms. But I thought, Michael, you pointed out the weaknesses or kind of the concern points of the trial. So you probably stated your conclusion a little more carefully than the authors of the ISAT trial did in their results, which I think is appropriate. So it's important to remember that there were relatively few posterior circulation aneurysms as part of this cohort. And that's one of the things that they tried to even out, if you will, in the subsequent BRAT trial. So here at the Barrow, in response to ISAT, Dr. Spetzler and the endovascular team here at the time was Dr. McDougall and Dr. Albuquerque. They basically kind of went head to head. And so they went every other day as a pseudo randomization of first attempt at endovascular versus first attempt at open surgery for all comers, for all ruptured aneurysms. And they continued that for several years. I think the total number of patients enrolled in the trial was somewhere around 500 patients. So fewer, but it was a single center. And so that controls for a lot of different variables. And then they also, were trying to put masters against masters. So Dr. Spetzler being an open-only cerebrovascular skull-based surgeon, and then two really expert endovascular neurosurgeons as well. So single center, high-level referral center for both. And they try to compare that, and they had slightly different results. So what that shows is basically some of the findings of ISAT have been replicated at times and have not been replicated at times. So some of the things that Michael mentioned of them being involved with only anterior circulation aneurysms. There were a lot of different centers. Some of them were high volume, some of them were low volume. Some of the surgical practitioners were not quite as experienced in doing aneurysms, and so that's going to decrease your quality of your surgical arm relative to the endovascular arm. And then, finally, just remember what that absolute risk number is. Anytime that people are presenting their trial results, it's easier to show a relative risk because it's going to be inflated a little bit. But the absolute risk is really going to show you how much are you making a difference, or how susceptible is it to maybe not being replicated. And so that absolute risk number of 7%, I think is real. It's been shown in other trials as well. And certainly I would say that most cerebrovascular specialists believe, if you will, in the data, or think it's quite legit from ISAT. But we have to remember that's not like, open surgery was that terrible and that people were being maimed left and right before the advent of the coil. It's still a good option. And so if you're smart about how you select your cases one way or the other, with the idea that you should generally default, all other things being equal, to endovascular treatment, then I think you kind of get the optimal outcomes for patients with ruptured aneurysms. There's a little bit of a long monologue. That kind of makes sense. Or anyone have questions for me about ISAT or how it affects kind of current modern practice, et cetera?
So my question, thank you, Dr. Srinivasan, for explaining all of that. My question would be, is there enough educational material on that one for clinical practice?
In terms of in residency, like how we learn about the trial?
Yeah.
I guess we've had it as like part of like our journal club. In my residency, we would basically have our regular journal club would be new papers, kind of state of the art stuff, and then in kind of smaller groups or at an individual hospital, or some attendings would do kind of here, go read the classic paper and then let's talk about it over coffee on Monday morning or something like that. And so, going back and reading these landmark papers, which is what you guys are doing here, is important. So I think we did have that, but I think it could be better. I mean, I had to go through, reading through ISAT and BRAT is there's not just this one paper. There are follow-up papers, and there's a 20-year follow-up of ISAT that just came out in Lancet a year or two ago. So that there's a lot that goes into it, right? So reading all of those papers and synthesizing them is quite tough. And so I think there could be more educational materials.
Okay, thank you.
One question that I had in looking at BRAT or at BRAT, so that had crossover. Michael, I don't know if you mentioned, did ISAT allow for a crossover at the discretion of the operating surgeon?
I believe that they did.
Yeah, I'm quite sure that they did. I don't know what I do remember that the numbers were quite high in terms of the crossover. So that was one of the things that when they were kind of doing the statistical modeling for BRAT, Dr. Spetzer harped on a lot was, they had less crossover in BRAT, but it was still higher, and it was essentially almost always one way. So it's almost always endovascular crossing over to surgery, and when that happens, when it's kind of like a one-way crossover, then that kind of brings into question your results. So, but pure statisticians will tell you that you have to do it as an intent to treat. But when you have high rates of crossover, over 20%, then it can sometimes invalidate those results.
Cool, thank you.
And the last point I'll make is a lot of people point to ISAT as like this turning point, which it is, and then assume that all aneurysms, that it applies to all aneurysms. So it's important to keep in mind that this was just for ruptured aneurysms, and that's really where you see the difference. You will probably notice at your individual institutions or where you rotate, there's a lot of people treating elective aneurysms with surgery. The difference between treating an elective aneurysm and a ruptured aneurysm with surgery is night and day. It's a very safe, you look at the kind of tumors that we take out with a craniotomy really safely all the time through a very similar arterional approach that we do with aneurysms. So remember that ISAT defines and drives the guidelines to where endovascular management of aneurysms, but that's for ruptured aneurysms. Elective aneurysms can be treated incredibly safely with surgery, and there's no randomized trial to show that otherwise.
Awesome, thanks for sharing that. It's always helpful to have some of the clinical insight on how it really applies in practice.
Yeah.
Also, Dr. Srinivasan, I realized I did not make you a co-host, so I can do that. And then if you want to be able to share your screen or put the video on or anything, you'd be able to.
Sure. All right, yeah, we can proceed. I'll have some slides that I can kind of pull up at the end if needed, but let's keep discussing.
Great. Okay, so now we'll have Laura and Kathleen to present the phases study, which was at the suggestion of Dr. Srinivasan. So it'll be great to hear his insight on that one as well.
Oh yeah, for sure. I am having a hard time sharing my screen there.
Is the icon present at the bottom for you?
Trying to find my screen.
Okay, if it ends up working to be easier, I can also share the slides that are on Google Drive that you shared.
Okay, that might be great. Thank you.
Yeah, no problem. Let me get pulled up.
That won't work for me as well because I have hard time doing it on my end as well. Not sure why. Sorry about
Okay,
that.
yeah, no problem. All right, here we go. Okay.
Awesome, awesome. Thank you so much, Michael. Thank you.
Course.
Thank you, everyone. My name is Laura. My co-partner, Kathleen, and I are going to be talking on phases score for management of intracranial aneurysms, a cross-sectional population-based retrospective study. So we'll start off with a brief, maybe overview of intracranial aneurysms. So what it is an outpouching of a weakened area in the wall of the blood vessels in the brain. And as you can see here, by the pictures depicted, we have to the extreme left a normal CT of the brain and blood vessels. And in the middle section, we have a CTA of aneurysms. And to the extreme right, we have a CT of aneurysms. So, so what is phases? Phases is actually an acronym for population, hypertension, age, size, early subarachnoid hemorrhage, and site. So what does it do? It allows for calculating the absolute 5-year risk of intracranial aneurysm rupture based on data that was provided by studies in the United States, Canada, Finland, Netherlands, and Japan. So this presentation will attempt to answer the question, is a scoring system like phases, can it be used to identify and classify the likelihood of an aneurysm to rupture? So currently the current hypothesis of phases is that it does a good job at matching decisions taken by multidisciplinary teams, whether or not to observe or to intervene. Secondly, it helps in classifying patients being diagnosed with a ruptured versus unruptured intracranial aneurysms. And third, it allows for discriminating between patients at low risk of rupture from the population of patients diagnosed with an intracranial aneurysm. So a bit of epidemiology here. So we have aneurysms of cerebral vasculature retrospective study on autopsies at 0.4%, aneurysms of cerebral vasculature prospective studies on autopsies at 3.6%, angiographic studies, a retrospective study, 3.7%, and angiographic prospective study at 6.0%. So a bit of background here on etiology and pathogenesis. We have genetic causes and acquired or environmental causes. But genetic, we have polycystic kidney disease, Ehlers-Danlos syndrome, neurofibromatosis, alpha-1 antitrypsin deficiency syndrome, Marfan's, and subarachnoid hemorrhage. For acquired, we have age, hypertension, smoking, alcohol, estrogen deficiency, and hypercholesterolemia and carotid artery stenosis. And pathogenesis, First, we have collagen deficiency, outpouching, impaired integrity of blood vessels, walls, and low collagen but elevated plasma elastase. And so the phase studies, what are the parameters? So the PE population in this study, the population involved were a North American other than Finnish. If you are in that group, it was 0 points, Japanese 3 points, and Finnish 5 points. In subgroup hypertension, if the person had no hypertension, then it was 0 points. If they have hypertension, then it's 1 point. And for age less than 70, 0 points, and for age greater than or equal to 70, 1 point. And the size of the aneurysm, if the size of the aneurysm was less than 7.0 millimeters, it was 0 points. And if the aneurysm was sized at 7.0 to 9.9, it scored 3 points. And if it was sized at 10.0 to 19.9, 6 points, and greater than or equal to 20, 10 points. So in this classification, if the patient has a history of a subarachnoid hemorrhage or another aneurysm, then they scored 1 point. If they did not, it was 0 point. And then last but not least was the site of the aneurysm. Where did it occur? If it occurred by the ICA, it was 0 points. And if it occurred by the MCA, 2 points. If it occurred in the ACA or posterior communicating or posterior circulation overall, was 4 points. And it's understandable because these are the watershed areas in the brain. So my co-presenter, Kathleen, will go over the methods and results at this time.
Yep. So onto the methods, they basically separate all the patients they enroll into 4 groups. So the S group is observed and stable, G is observed and growing group, T is immediately treated, and there's another aneurysm that is ruptured. And then further categorize this 4 group into 2 groups. So the S and G combine to become a follow-up on ruptured aneurysm, and the GT and the subarachnoid group, hemorrhage group, becomes the high risk of rupture group. And so they claim that they want to assess whether the phase score provide any decisional support. So they do that by comparing the F versus T group, and then whether the phase score can classify unruptured from unruptured. So that's the unruptured group versus the SAH group, and whether phase score can discriminate patients' risk of rupture. So they compare the S versus the H group. And in total, they enroll. So from the very beginning, they have 1,164 patients, and then they roll down to 841 by excluding the patient who has like polycystic kidney disease and have family history. So it's a pretty homogeneous group. And so they have 841 patients in total, with 598 on rupture and 243 that's ruptured. So on to the next page. Thank you. So the graph on the top shows like a distribution of the phases score in the full cohort, and then you can see that it peaked at 4 and it grew toward the lower values. So most patients in the follow-up group, which is basically the stable and S and G group, have a score between 1 to 4, and then T is the immediate treated group, have a score between 3 to 7, and for the subarachnoid hemorrhage group, it has 4 to 8. So you can see that the score is actually like a positive correlation that's higher from patient who has lower risk to higher risk. And the median phases score for each, and for the second table here, they analyzed each group individually and then found that there's statistically significant difference between each group, and also like an increase in correlation to an increased estimated risk of aneurysm rupture. Yeah. Next page, please. So they conclude that they can't state a conclusion So there's a threshold set between 3 and 4. So patients has less than 3 or more than 4 can predict the rupture, whether they should treat it or not. So they claim that the FACES score can provide decisional support on whether to observe or intervene the patients with unruptured aneurysm. And then they also classify unruptured versus ruptured aneurysm by using the threshold 3 and 4, and then also discriminate patient at lower risk of rupture. And so just in kind of more like a comprehensive conclusion, so patient who has greater than 4 FACES score you should intervene, and then the intervention risk is considered lower and less than 3. So they conclude that greater than 4 is have higher risk of intervention, and then less than 3 has lower intervention risk. Sorry, that's probably a mistyping. And for the strength of the study, it is a prospectively collection of information on consecutive cases. So this can reduce the selection bias. And it's generally pretty well designed and has provide very detailed algorithm, how they stratify patient, how they separate patient into each group. And they provide a table for all the demographic and the aneurysm characteristic and claim that they are pretty similar. However, they didn't provide any statistical analysis, like not even a p-value to compare each group. So we don't really know whether there's like a significant difference or not. And the last strength is the follow-up time is the mean follow-up time 3.2 years, which is considered pretty good for the aneurysm studies. And for weakness, like I said before, the threshold is they didn't mention how they determine the threshold. They basically just throw the number out and say you can use this threshold to separate the patient to see whether there's a risk of whether to intervene or not. And the number of patients in each of the subgroup were kind of unbalanced, so it may lead to underpowered statistical analysis as well. And also, I think we probably should mention that treatment recommendations should not be based solely on the aneurysm rupture risk, because like individual treatment should be considered like individualized based instead of just using the FACE score. Yeah, that's all we have. Thank you.
Great, thanks, guys. So maybe we can open it up to any questions from the audience, and then Dr. Srinivasan can step in. And for the attendees, if you have any questions, feel free to use the Q&A function or the chat box.
Yeah, just leave it for questions for a second before my commentary. Okay. Yeah, so that was a great job, Kathleen and Laura. I'll kind of share some slides while I think that kind of match up with this topic pretty well. So here, I'll share my screen here. So I chose this as opposed to ISUIA for a reason, and that's because I think it kind of is the modern extension of the same concept, and that's basically this. So, amongst all aneurysms here, we have our ruptured aneurysms. We talked about that already with ISAT a little bit. And you have your unruptured aneurysms. And unruptured aneurysms come in 2 flavors: either your ones that are symptomatic, like they have third nerve palsy with a PCOM aneurysm, or some other cranial nerve palsy, from a large aneurysm, or MCA aneurysms can get giant and cause seizures even. Those are really rare. The majority of unruptured aneurysms are incidental. So that's what we're focusing on. And when you're trying to decide what to do with an incidental aneurysm, asymptomatic, unruptured, you have these 2 things to balance: your risk of your intervention, and then what is the natural history or the rupture risk. And truthfully, both of these are sort of black boxes. We don't really know for sure. Patients ask us, and we'd like to know, but we don't know for sure, right? And so the first black box to figure out there is this natural history component. And that's kind of what phases is getting at. It takes ISUIA amongst a couple other studies, and it, these are some of the other ones. Juvella et al. Is that Finnish study, Suave, and some of the others are the Japanese study that all went in there, UCAS amongst them. And it combines it in a really interesting and useful way to understand what's happening in this black box. So these are some of the things that were previously known before the phases study, in small individual studies, that these are the factors for rupture. Not all of these actually made it into the phases study, either because it didn't work out in terms of the effect size, or by their statistical analyses, their logistic regression, it didn't work out. But these are the ones that have been previously described, and the ones that are in phases, turned out to be large effect sizes. I think a nice study, which I'll just quickly show, that pairs well with phases. We'll get to that in a second. So this is from the phases paper. You kind of showed this, but basically, as you jump in the higher phases score, you have an increased risk of probability of aneurysm rupture. And basically, as you kind of get from 3 to 4, and certainly above 4, you're above 1% rupture risk for your 5-year rupture risk. And in the majority of patients, that's usually sufficient to suggest treatment. So that's kind of where the borderline is. You don't want to treat someone with almost no points, but as size increases and as it gets to riskier locations like the ACOM, PCOM, and posterior circulation, that certainly tips us in favor. Some of the weaknesses that you guys already mentioned of the phases score are important. I think the phases score is very useful. I use it, in my clinic every week. I have a smart phrase on Epic that for every unruptured aneurysm that I see, I quickly calculate the phases score. My smart phrase gives me the actual numerical risk of rupture, and I cite that to the patient often. I might round it, but I will cite it for them and then tell them, yeah, well, this is what the phases score says, and that supports my recommendation to do either observation or some sort of intervention. And it's important to kind of give patients something of a number, but it's not everything, because that number does not take into consideration some other factors. I think population, for example, is kind of a fraught one, because there have been things that have been described in the Finnish population, Japanese population, that they have genomic differences in certain SNPs that have been associated with aneurysm formation. But that doesn't mean that others are at lower risk. It just means that they haven't been studied, right? We don't have, other Asian populations, other European populations haven't been studied. I'm of Indian descent. There's no study in India that's been done to try and define that population risk as being any different than others. So that's kind of a lack of knowledge that fits in there. And then the other part is size of aneurysm. One of the weaknesses of all of the studies that went into phases, including ISUIA, is that they didn't have a lot of aneurysms that were small. And if you look at some other studies, which I'll kind of go through here, this is a study from Hopkins that has shown basically, as time has gone on from the 1990s till the modern era, the proportion of aneurysms that are small or very small. So if we're considering that 0 to 5, that's this lower black bar, it's gone from representing under 30% to now 50% of all the ruptured aneurysms that show up at Hopkins are under 5 millimeters. And now if we go back a few slides to phases, you get 0 points for being under 7 millimeters, right? Yeah. And so, if you have a patient who is North American, like many of our patients are in the US, let's say they do have hypertension, they're 69 years old, they have a 3 millimeter or 5 millimeter ACOM aneurysm, they may not have that many points to really suggest treatment, right? But I'll tell you, I've seen dozens of aneurysms rupture at that size and show up in RER. So that's just, when you have flawed data going into something, so the data being flawed here were from ISUIA and UCAS and others, where people were enrolled in that study because they had equipoise for treatment versus not. the ones that were looking scary to the treating neurosurgeons were filtered out. And so what ends up in the phases study is aneurysms that were elected for observation. They try to account for that by including those ruptured studies, of course. All right, so I mentioned the 2 black boxes, right? So these are our 2 black boxes, right? One is natural history, which phases I think does a pretty good job of answering that. Not perfect, but it's certainly better than anything else we have, and it's pretty good. And then the other side is risk of intervention. So that's why I don't just use phases alone, but I need to be able to tell a patient that not only do you have a 1% risk of rupture of your aneurysm over the next couple of years, but what we can do for you is treat this and do so safely, and that risk is less than the risk that the aneurysm poses to you, right? And so we're not discussing this in this thing, but I just kind of wanted to put this earworm in your minds if you're interested in reading about it or interested in cerebrovascular, is this UIATS score. So what this is basically all of the different risk factors that have ever been discussed for affecting a patient's outcome from intervention. So that includes their age, there are other comorbidities, and then some other factors like the treatment factor. Are we doing surgical treatment, endovascular treatment? Is it a complex looking aneurysm? All of these things kind of go together. And then they try to balance it out here. At the end, you get this score where you kind of balance out the treatment score versus the aneurysm natural history score. So it doesn't give you a perfect number. It's always hard to say like, okay, your lifelong risk of an aneurysm is 2 to 3%. But if that happens, you're probably dead, versus like, are you willing to get a cut on your head and get an open aneurysm surgery? So that's always a little hard, but at least having these numbers helps us to have informed discussions with patients. So anyways, in short, great job to both the groups for discussing that. I'll just kind of give an inspiration for, cerebrovascular disease is extremely interesting. Aneurysms probably the most interesting part of it. And treating both ruptured and unruptured aneurysms is highly challenging. It's very kind of invigorating from a technical standpoint. It's interesting from a cognitive standpoint in terms of just thinking about these diseases. The decision making is just as challenging as it is in spine or other areas of neurosurgery in terms of trying to figure out how you balance these kinds of risks. It's interesting to think about. It was the reason I went into neurosurgery as a med student, and actually ended up doing it. But anyway, I encourage you all to seek it out if that's something you find intriguing. I will be at joining the faculty at University of Pennsylvania in Philadelphia. So I'd certainly encourage you guys to, if you're interested in looking at a sub-I there, I'd be happy to see you and working with you in that setting as well.
Congratulations.
Thanks.
Congratulations.
Hey everyone, Ryan Rad here from neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.